Welcome to this lecture. We're going to talk about 3 specific joint-related disorders. So we're going to talk about osteoarthritis, not to be confused with rheumatoid arthritis, and you'll see why. We have gout and fibromyalgia. So first, let's talk about osteoarthritis, also known as OA. It's the most common non-inflammatory joint disorder, and it specifically involves the cartilage around the end of the bones that make up your joints, like in your knees. Remember, cartilage serves to cushion and protect your joints, and there's also a space in between with synovial fluid that allows for smooth movement. Typically, after an injury to those joints, the cells found in healthy cartilage, known as chondrocytes, will repair the damage, but over time or after repetitive injury, they will become overwhelmed, so they won't be able to keep up in rebuilding it, which results in osteoarthritis when we get a progressive breakdown of cartilage. The cartilage can wear off and narrow the space between the bones up to the point that those bones will start to grind against each other and it will cause formation of bone spurs. And you can think of those like calluses that form around the bone from constant friction. Since we no longer have that nice cartilage and space, it's going to affect mobility. As you see, the process of OA worsens over time and there is no cure, so that's why it's also called degenerative joint disease. What makes OA different from rheumatoid arthritis is that it will be limited to the affected joints. So patients may just have OA on one joint but not on the other side. And there isn't going to be any systemic symptoms because it's more of a local problem. We most frequently see OA in joints that are weight-bearing like the hips, knees, and spine. So in the past, osteoarthritis has been seen as a wear and tear disease because one of the main risk factors is aging. Research says that by age 40, joint changes begin, but patients may be asymptomatic. So no joint pain, no other signs and symptoms. But approximately 85% of older adults have x-ray evidence of OA and clinical symptoms. Women, especially those who are Hispanic or African American, are more commonly affected. Females have wider hips than men, so this can place a slightly greater load on the knees. And it could also be due to hormones affecting how chondrocytes function, especially after menopause. We also see that genetics has a role, like if it runs in the family, it may increase your chances of developing OA. My abuelita, or grandma, she has OA, and I'm probably going to refer to her a lot during this section. The most common modifiable risk factor is obesity. Think about it. All that weight has to be supported by what? Your knees. Yes, and so over time, it can lead to damaging those joints. People with occupations that use their joints repetitively or carry heavy loads or have to stand for long periods of time, like 12 hours. That's right, like nurses. So please take care of your back and joints because we are at risk for OA. People with history of previous joint injuries from trauma or high impact sports also have an increased risk. So OA is not only due to aging, it can also affect younger patients. Like when I was playing basketball in high school, I remember my coach saying, if you see the ball on the ground, you should also be on the ground. So I did exactly that. And what part of me was on the ground first? My knees. And my mom would tell me to be more careful, to not hit the ground so hard with my knees, or else I would feel it as I got older. And she doesn't have any medical experience. And trust me, I should have listened to her because she was right. Osteoarthritis is typically diagnosed with an x-ray. Remember, it's a local problem, not systemic, so other blood tests won't tell us much. So if you look at the first x-ray, you can see a normal knee with a nice little black line in the middle, meaning we have a healthy joint space. In the second x-ray, take a look at where that arrow is pointing at. We don't see that nice space anymore. which means we have lost that protective cartilage. Bones have started to grind against each other, and it will create bone spurs. And when those form, it will make the bone look larger than it is. So that's how we diagnose osteoarthritis. We could also do a MRI to look at the cartilage since it's a soft tissue, or an arthroscopy, a procedure in which the provider inserts a small tube or scope through a small incision to visualize the joint, as you can see in the far right photo. We don't do this as much because patients need to bend the joint at a certain angle, and as we just mentioned, patients may have limited mobility. But in this image, you can see the bone spurs, which is pretty cool, but it's painful for the patient, as you can imagine. Most of these patients are going to seek help because of local joint pain and tenderness that has gotten worse over time. Remember, it's progressive. Joint pain is usually aggravated by movement or exercise and relieved by rest. However, rest can be a double-edged sword, like when they go to sleep, their joints are not being used, so their pain has decreased. But not using that joint during the night will cause stiffness in the morning when they wake up. But it usually lasts less than 30 minutes as the joint starts to warm up with movement. However, at the end of the day, they will feel that local joint pain again after walking or standing all day. They can also have local swelling caused by excess fluid within the synovial space due to the irritation, and that swelling is going to make the joint look larger when compared to the other, as you can see in the photo. As we mentioned, patients may also have limited range of motion. And remember, when cartilage has completely worn out, the bones will start to grind against each other. And when that happens, they produce a sound known as crepitus. It's like a crackling or grating sound. So, yes, those are the bones. You can also feel it, especially over the knee joint when they bend it. I think I have a little bit. If OA affects the hands, they can develop bony enlargements that are firm, usually not painful, but it can decrease their fingers' range of motion. We call these Bouchard's or Heberden's nodes, depending on their location. The way I remember is by alphabetical order. So the B in Bouchard's comes first in the alphabet, and Bouchard's node is going to be in the joint closest to the body. Heberden's node is further away from the body in the most distal joint, just like the letter H is further down in the alphabet. So hope that helps. Since there is no cure for OA, the goal is to decrease pain and maintain or improve joint mobility. Here we have a list of oral analgesics to help reduce pain day by day. We start with the ones that have the least amount of side effects, like acetaminophen, the Tylenol, which is going to reduce the amount of prostaglandins in the body that contribute to pain. But remember, patients should not take more than 4 grams of Tylenol in 24 hours because it can lead to acute liver failure. If they already have some type of liver issues, it's probably best to avoid this because they're going to be on it daily. Some patients may have better pain relief with NSAIDs like ibuprofen, but if you remember from pharm, long-term use of NSAIDs or taking them inappropriately, like without food, can cause GI ulcers or ulcers in the stomach or even bleeding. And we'll talk more about that when we cover GI disorders. If patients have a history of kidney issues, we'll probably have them stay away from NSAIDs because, again, long-term use can be toxic to kidney function. For severe cases, we may use opioids like tramadol or hydrocodone with acetaminophen, which is Norco. However, long-term use increases the risk for dependency since these act on the CNS. So that's why it's last resort, or at this point, they may need more invasive treatment. Pain medication can also be topical. For example, diclofenac sodium gel is used by massaging it around the joints like the hands or knees. The skin will absorb it and it'll temporarily relieve the pain. It's pretty safe, so my abuelita uses it very frequently, and it helps her during the day as she's walking and doing all her other activities. Bengay and other over-the-counter creams can also help if they include methyl salicylate. Another thing we can do, which is a little bit more invasive, but it can also help with mobility, it's called viscosupplementation. This is basically an injection of a gel-like fluid, like hyaluronic acid, that is injected into the joint. As you can see in the photo, that blue gel will act like a cushion between the bone ends, which improves pain and mobility. It can last a couple of weeks or months, but research shows that it doesn't always work for everyone, so just keep that in mind. So, the medical management we just discussed should go hand in hand with other lifestyle changes that we can educate the patient on, such as having them plan their daily activities when their pain is least severe and plan to use pain relievers before exercising. And we do want them to exercise daily to maintain mobility and slow down the progression of osteoarthritis. The exercises, though, should be low impact, meaning it's not going to be too hard on the joints like running or jumping rope when all that pressure falls in those weight bearing joints. So, examples of low impact exercises include walking, water aerobics, yoga, or Pilates. We also want them to do strength training like biking, which is going to strengthen the muscles around the joints and provide extra support. And because obesity is one of the main modifiable risk factors, losing weight would be a great idea to offload pressure from those joints and improve pain. Remember, we also need to teach patients about the type of pain meds they're taking and potential side effects, and they should also rest any painful joints. They could also use assistive devices like canes or walkers that can help them move better and decrease the amount of pressure on the joint. And complementary therapy includes applying ice or heat packs for comfort. They could also try transcutaneous electrical nerve stimulation, TENS. And if you look at the bottom right picture, the TENS unit is a small device connected to electrodes that are placed around the joint. And when you turn it on, the unit is going to send small electrical shock waves to the nerves. It doesn't hurt, it just feels like small vibrations, and it will basically help with the pain signals in that area. The relief lasts for a couple of hours, and if you wanted to try it, you can easily get these on Amazon. Surgery is going to be the last resort for these patients, typically when other conservative measures have failed to improve their severe pain and now they have disability and they can't do activities of daily living. So, in an arthroplasty, the surgeon is going to remove the affected joint surfaces and replace it with synthetic materials, as you can see in the photo. Or they can remove all the components of the joint, which we typically call a total joint replacement. And the most common are hip and knee total replacements, but it can also be done in other joints like in the fingers. Now, this procedure is very invasive, as you can see, but with the current technology and evidence-based practices, this has become a fairly safe procedure, and serious post-op complications are not very common. I actually worked at a hospital that was certified to do these joint surgeries, and this is just a preview of what post-op care I would always do with my patients, which you'll learn more about in Adult Health 3. But anyway, it's important to assess their surgical site, look at their drains, monitor for signs and symptoms of bleeding. We want to avoid infection and blood clots, so we would give them medications for prevention. We're going to treat their pain. We also are going to have the patients up and ambulating that same day. It's proven that it's going to decrease their hospital length of stay and any type of complication. After surgery, they will have relief of pain and regain mobility. And this is very true. I got to see it firsthand with my patients and also be on the other side when my abuelita got her total knee replaced. I just loved caring for these patients because there was a lot of hands-on skills and I was just happy to be a part of their journey to improve their quality of life. The next disorder is gout. The patho is pretty simple. Typically, when you eat certain foods high in purine, like red meats or seafood, the body will break those purines down to uric acid, which is the byproduct. And then our kidneys are in charge of flushing that uric acid out through the urine. So, what would happen when the kidneys can't excrete enough uric acid, or if the body is producing too much? That is going to cause a buildup of uric acid and increase that concentration in the blood, which we call hyperuricemia. So, gout can be due to overproduction or too little excretion of uric acid. If we don't correct the high levels in the blood, it will start to form crystals, as you can see in the middle picture. Those crystals are made up of uric acid. They're small but very sharp. And when they migrate to different joints, most commonly the metatarsophalangeal joints like the big toe, they will cause inflammation and severe pain. Gout can progress through 4 stages. In the initial stage, patients will have elevated levels of uric acid in the blood, but no clinical symptoms. So that's why it's called asymptomatic hyperuricemia. And we do want to catch patients here to start them on treatment early on, and it can even prevent them from reaching stage 2. However, because they don't have any signs and symptoms, patients won't think anything is wrong until they have reached stage 2, which we call a gout attack. And this is when patients will come in and report severe pain in the affected joints. They'll look red and swollen, as you saw in the last slide, and those acute flares may need medical management, but they typically get better on their own in a few days. When patients are symptom free after an attack, that period of time is known as stage 3. So it can be back and forth between those stages. Now, if that hyperuricemia remains uncontrolled and patients have repetitive acute flares throughout the years, patients will end up in stage 4, where they now have permanent joint damage and even systemic complications. So, who's more at risk for developing gout? We see that the risk increases with the aging process. Gout is 3 to 4 times more likely in males, and it can also be due to genetics. Like I've seen it in a couple of my Filipino friends who have told me that their parents and grandparents had gout as well. We see obesity as a risk factor again. And remember, one cause for gout is overproduction of uric acid, and it has a lot to do with diet. So, increased intake of foods and beverages high in purine, as the ones you see here, will be broken down to uric acid, and it'll increase levels that way. The second reason has to do with under-excretion, so decreased removal of uric acid by the kidneys, which can happen when they're busy breaking down something else like alcohol. Same thing with some anemias and cancers. The kidneys are busy filtering out abnormal cells or debris and prioritizing their removal. Patients that have hypertension or diabetes, especially due to obesity, are at risk for renal disease, which means their kidneys won't be able to remove uric acid. And if they're taking long-term medications like diuretics and aspirin, those can increase uric acid levels as well. To diagnose gout, we will take some blood and look at the uric acid level. So the range for uric acid can vary among facilities and males versus females, so you don't have to memorize this lab value. But we typically consider patients to have hyperuricemia if it's greater than 7 milligrams per deciliter. We could also collect a 24-hour urine sample and analyze how much uric acid is being excreted by the kidneys. And the definitive diagnostic test is going to be a synovial fluid analysis, which is exactly what you see in the bottom picture. We will collect the synovial fluid of the affected joint through needle aspiration and send it to the lab, where they will look for the uric acid crystals. If it's positive, then we know the patient has gout, and that's why they're having pain and other symptoms. So during a gout attack, patients are going to have severe joint pain, as I already mentioned. The site will have redness, swelling, it'll be warm and tender when you palpate it, but I don't think they'll let you because they don't want anything touching it. Some patients that have it in their knee or toe may not be able to put any weight on those joints. Like sometimes they can't even put on shoes because it'll cause those sharp crystals to move around and it'll cause extreme pain. I remember my coworker would have to call off sometimes because he would get these sudden gout attacks and he could not walk on it at all, nor did we want him to for 12 hours straight. So, even though we most commonly see it in the big toe, it can still happen in other joints like the shoulder, finger, and even elbows. Do you remember when I mentioned systemic complications can happen over time? So here are a couple of those. People with gout are 60% more likely to develop kidney stones. And again, it's due to that uric acid building up and forming calculi that can get stuck anywhere in the urinary tract. If they get trapped in the kidneys, they can cause tissue damage and it can lead to renal impairment. The high concentration of uric acid can also create plaques in the blood vessels, leading to an increased risk for cardiovascular disease. And after years of gout, we will see tophi, which are bumps underneath the skin that grow from the accumulation of urate crystals. They're usually not painful unless they're inflamed, like during a gout attack, or if they're pressing on a nerve. Common places for tophi are the toes, tophi toes, around the ear, and other joints. You can even see a little bit of white peeking out, kind of looks like cottage cheese. And they can cause deformity, decreased joint mobility, and possible infection. So some patients may need to get these surgically removed. We want to avoid patients from getting to this last stage, so we need to provide good education on how to decrease their uric acid level. To treat gout attacks, we can use NSAIDs like indomethacin or a steroid that is going to decrease the local inflammation and pain. And right at the beginning of the gout attack, patients should take colchicine, a medication that will slow down the buildup of those crystals and reduce the WBC response, thereby reducing inflammation. Patients can take this medication by mouth right away, and they could take another dose after an hour or as prescribed until the pain is relieved. But they should stop taking it if they get any GI symptoms like nausea or diarrhea because it can be a sign of toxicity. Colchicine has a very narrow therapeutic index, so we need to find that perfect dose for the patients so that they don't get these side effects. And to reduce the already high risk for toxicity, patients should avoid grapefruit juice while taking this medication. So, colchicine is the only gout medication that is used for acute attacks, but it can also be given daily for long term management to prevent future attacks as well. So, these next medications are only used to prevent gout attacks by decreasing uric acid levels over time. They are not going to be used for gout attacks. Remember, we only use colchicine for that. And that's because it will take time to see the therapeutic effects. So sometimes patients will take one of these two meds and colchicine during gout attacks. Just remember, colchicine did nothing for uric acid levels. So the first medication for prevention in this list is allopurinol, and it works by inhibiting the action of the enzyme that is in charge of breaking down all those purines. So that's how it will decrease the production of uric acid. Secondly, we have probenecid, which works by increasing the excretion of uric acid through the urine. So, because these medications have decreased uric acid levels, it will prevent crystal formation and future gout attacks and chronic complications. But for patients to have optimal results, they need to take these medications daily. For nursing interventions during a gout attack, we want to do lots of pain management. They should rest in bed, put any cooling measures to reduce the inflammation if they can tolerate it. And remember, any type of pressure or weight on those joints can worsen the pain because those crystals are shifting. So they may not want any socks or even linens or blankets on top of them while they sleep. So they can use a bed cradle to keep those blankets off or elevated. Again, we need to educate them on the medications to prevent gout attacks, which studies have shown that many patients stop taking their medications every day because they feel better, they don't have symptoms. But then unfortunately, they will come back to the clinic or the urgent care with a flare up. So please let them know that they need to take it daily. And for the best prevention, lifestyle and dietary changes should also be made, like drinking 2 to 3 liters of water every day to help flush out the uric acid, restricting foods high in purine, achieving a healthy weight, and reducing stress, which all will help in preventing gout attacks. I'm emphasizing dietary considerations because you already know it has a direct impact on uric acid levels. So, patients with gout should increase their intake of fruits and vegetables, especially those that are rich in antioxidants like dark berries, cherries, spinach. All of those can help to reduce inflammation. They should eat whole grains, nuts, and find their protein in things like eggs instead of red meats if possible. I know patients are not expected to become vegetarian or vegan overnight. We can only, recommend, but they should try to look for low fat or fat free dairy products and at least reduce their consumption of meat. It is best to avoid seafoods, alcohol, and high sugary beverages, though, because those have excessive amounts of purines. Finally, let's talk about fibromyalgia. This syndrome is characterized by chronic, widespread pain, including muscle achiness and joint stiffness, chronic fatigue, and it can eventually lead to functional impairment, which we'll talk about a little bit later. It used to be considered a psychiatric disorder because these patients were reporting constant pain, but their lab values and all other diagnostic tests were normal. But ongoing research has shown that these patients are, in fact, in actual pain, so it's a real syndrome. The exact cause, though, is still unknown, but the general thought is that the central nervous system and its pathways in charge of moderating pain signals will abnormally process those signals and amplify them, resulting in heightened pain from stimulation that isn't normally painful, like a touch or a pat on the back. Think of it like a car alarm system that is overly sensitive and how it starts to go off by a gentle breeze or a small vibration. In fibromyalgia, the body's pain alarm system is also hypersensitive like this. It's estimated that here in the United States, approximately 2 to 5% of the general population have fibromyalgia, with women being affected more than men. Family history may increase the risk of developing fibromyalgia as well. Other predisposing factors could be anxiety, depression, history of sleep disorders, and if they don't have any of these, unfortunately, we do see that these patients start to develop them due to the chronic pain, which can be really hard to live with. Physical trauma and psychological stress can trigger and aggravate fibromyalgia symptoms. Your book also mentions that viral infection can be a trigger for that nervous system to function differently and therefore impact those pain signals. There's no single test that can confirm a diagnosis of fibromyalgia, which means we will usually have to rule out other conditions first. And then we'll proceed with a comprehensive assessment, including their history, like if they had any trouble sleeping, and then we'll do a physical exam. The provider will also do a detailed pain assessment using a tool like the PQRST scale, as you can see below. So they'll ask questions about their pain, like what makes it worse or better, what is the quality or characteristics of it, where is it located, how severe is the pain, and how long has the pain lasted. If symptoms have been consistent for the past 3 months, it is a big red flag for fibromyalgia. Asking these questions will be very important because while someone with, let's say, osteoarthritis, those patients can usually point to a specific body part like their knee joint that has swelling, redness, and stiffness, but patients with fibromyalgia tend to report widespread pain and tenderness in larger areas like whole quadrants of the body. The last thing we could do is count tender or trigger points, which is done by palpating 18 spots throughout the body. And if the patient reports pain in 11 out of those 18 points, it could be consistent with fibromyalgia. This used to be the go to test back in the 90s, but with ongoing research, it has shown that it's not as reliable because providers were not using enough pressure, to elicit a response, and then patients' responses were very subjective. So that's why the current guidelines say that it's no longer required. Just like I've been saying, fibromyalgia can be very debilitating, and clinical presentation can vary among patients. As you can see in this picture here, they can have a wide variety of symptoms, and I mainly want you to focus on a couple of them. The first is allodynia, which means extreme sensitivity to touch. For example, I've heard some patients can't tolerate wearing certain fabrics or clothing pieces like a bra because it can trigger chest pain. Or sometimes they may not want to shower because the pressure of the water can also be painful. That's how hypersensitive their system is to touch. So, allodynia. They also have generalized muscle aching and they can have poor sleep because they're constantly feeling that achiness. And if they're not getting their restorative sleep, it will lead to chronic fatigue and other complications. The vicious cycle of chronic pain among patients with fibromyalgia can lead to some complications, like they're constantly stressed out at the fact that they can't do many things in their daily lives without triggering or worsening the pain. So they can start to develop anxiety and depression. Because they have poor sleep, they'll be sleep deprived, and eventually that can affect their cognition and their memory. Patients usually call it fib fog when they can't remember short term events or they have difficulty concentrating. And as an attempt to cope or treat the pain, they can resort to taking opioids or alcohol over and over again, which increases the risk for abuse and dependence on those substances. I know someone whose mother has fibromyalgia, and she let me share that her mom would not get out of bed all day at times. She was depressed, she couldn't hug or touch her, and at one point, she did become dependent on alcohol. We see cases like this more often when patients don't feel that providers believe their symptoms or they're not on the right treatment. Patients can also become sedentary to avoid painful stimuli, so that can lead to weight gain, obesity, and you already saw that obesity increases the risk for other conditions like heart disease, diabetes. So, proper management will help us prevent these complications. So, unfortunately, there is no specific treatment or cure for fibromyalgia. So, the number one goal is symptom management. We can give them NSAIDs and muscle relaxers like methylcarbamol, which can help with their muscle aches and joint stiffness. If they describe their pain as burning, pins, or needles, that can mean nerves are involved. So, they will be prescribed Lyrica for their nerve pain. And that's why it's so important to ask these patients to describe their pain very specifically so we can give them the right medication. Moving on, as you've learned in psych or will learn, SNRIs and SSRIs will increase serotonin to reduce symptoms of depression and anxiety. Cymbalta specifically can also help reduce pain and restore a normal sleeping pattern. And if their sleep improves, their thought process will too. And they'll be more willing to do other lifestyle changes like exercise to promote dopamine, that happy hormone that helps with memory and other things as well. As you've seen, fibromyalgia can be very difficult to diagnose, so it's going to be very important to actively listen to your patients and acknowledge their concerns. That is going to go a long way in their stress and anxiety. So, if we pick up on those red flags, then we can refer them to a specialist who can officially diagnose them and put them on medications as needed. But we're also going to include lifestyle changes, like encouraging sleep hygiene practices, similar to the ones that we discussed in the Gerald lecture, like having them sleep at the same time each day and avoiding caffeine before bed. We also want to encourage them to exercise as tolerated because they'll reap so many benefits, like improved mobility, improve their stress levels, and help them maintain a healthy weight. They can also eat antioxidant rich foods to reduce symptoms because some studies say that these protect nerve cells and they can even help with the pain signals. Patients can also join support groups that consist of other people living with fibromyalgia, where they can discuss how they cope with it so they won't feel so alone. And cognitive behavioral therapy can also help with their coping skills rather than having them resort to opioids for long-term use. And lately, acupuncture has shown promising results with pain management as well.